Placentitis. History. Placentitis is an important cause of abortion, stillbirth and perinatal death in horses. Different etiologic agents such as viruses, equine viral arteritis and equine herpes virus 1, bacteria, beta hemolytic streptococci, Escherichia Pseudomonas aeruginosa, Klebsiella pneumoniae, Leptospira spp and Krousiella equui, and fungi, Aspergillus spp and Mucor spp, have been implicated as causative agents. Depending on the microorganism involved, several routes of infection are possible. Diamond suit ascending infections are common, resulting in inflammation and detachment of the choriolantois at the level of the cervical star. Diamond suit hematogenous infection of the fetal membranes has also been described. This is the primary route of infection for Leptospira spp, which cause a diffuse or multifocal placentitis. Viruses also gain access to the placenta and fetus via the hematogenous route. Diamond suit, a unique form of placentitis, is caused by the bacteria Krousiella equui, nocardiiform placentitis. It has been suggested that the organism gains access to the mare's uterus during breeding and remains latent until later in gestation. The characteristic lesions are localized at the level of the uterine body. Clinical signs. Clinical signs of placentitis may include premature udder enlargement and lactation, cervical relaxation, vaginal discharge, abortion, stillbirth and premature delivery. Most mares with placentitis do not become systemically ill and the hemogram remains within normal ranges. Placentitis can also result in the birth of immature or dysmature foals, small for gestational age foals or neonatal sepsis. Differential diagnosis. Other causes of abortion, stillbirth or premature delivery. Placental changes may not be evident to the naked eye and a complete postmortem examination should be performed on any aborted fetus with samples of placenta and appropriate fetal organ samples taken for histopathology. Diagnosis. Clinical signs. Any mare with premature udder development or a vaginal discharge should be regarded as having placentitis until proven otherwise. Normal complete cell count and fibrinogen. Samples obtained from the vaginal or cervical discharge should be submitted for culture and cytological examination. Transrectal ultrasonography is performed in order to image the area at the level of the cervical star. Ultrasonography may show an increase in the combined thickness of the uterus and the placenta, CTUP, edema of the atlantochorion and placental separation. The CTUP should be measured in the ventral part of the uterine body as placenta in the dorsal part is often thicker, with edema of the dorsal placenta being found in a number of normal mares in the last month of gestation. The normal CTUP values by gestational age are less than 5 mm, 270 days, less than 8 mm, 271 to 300 days, less than 10 mm, 310 to 330 days, less than 12 mm, 330 plus days. Transabdominal ultrasonography is an important tool to assess the placenta at the level of the body where nocardiiform placentitis occurs. The mean utero-placental thickness as measured by transabdominal ultrasound should be 11.5 plus or minus 2.4 mm in late gestation. Another very important use of transabdominal ultrasonography is to assess the fetal well-being in mares with suspected placentitis. Fetal heart rate, FHR, movement, and growth can be checked and the turbidity of the amniotic fluid can be assessed. Treatment. Broad-spectrum antibiotics such as trimethoprim sulfadiazine or agentamicin and penicillin combination are good initial choices and have been shown to achieve acceptable levels within the fetal fluids. Non-steroidal anti-inflammatory drugs, FL-unixin meglumine or phenylbutazone, are used with the objective of decreasing the level of inflammatory mediators released during placentitis. Altrenogen used at a double dose, 0.088 mg per kilogram every 24 hours, may be of benefit in the treatment of uteroplacental inflammation secondary to placentitis, although this remains controversial. Progestins are also thought to decrease myometrial activity. Pentoxifylline and aspirin are other controversial treatments that are thought to improve placental perfusion.